Usually if they need an NG tube, it's because they're distended. They could be bleeding, you know, their stomach could be bleeding or whatever, or they've got a bowel obstruction and things are backing up, either way. If they're in excruciating discomfort, I may put the NG tube in before I do the head to toe assessment. If they're not in a huge amount of discomfort, I may go the other way, just because maybe this is the first time I've actually laid eyes on them, or I just want to check them out really good before I do the NG tube. So it's just based on what's going on with the patient. In this case here, I'm going to do the head to toe assessment first. That doesn't mean that you have to do it that way. So a lot of your scenarios, like when we do Foley's, it's a sterile procedure. You don't have to record yet, because it's going to make your deal too long. But when we, so you come in, I've got all my stuff here that I need to do everything, okay? And I'm going to start with the head to toe assessment. All right. So you just go in and introduce yourself. Hi, I'm Nick. I'm your nurse this morning. How are you feeling? Oh, I'm having some pain. Where's your pain at? Oh, it's like right here. How bad is it on a 0 to 10 scale? 0 being no pain, 10 just the worst pain you can imagine. Oh, it's about a 3. Okay, all right, 3's good, so we can continue on. Can you tell me your name and date of birth? Tells me his name and date of birth. And then I'm just gonna say, I need to do a complete exam, a head to toe assessment. So we're gonna go ahead and get started, and then the doctor's ordered an NG tube. Once we complete the assessment, then I'm gonna put the NG tube in for you, okay? Okay, all right. So I'm just gonna get started. You got your pen light, his eyes are closed. Their pupils aren't gonna react either way, but you just take like this. Watch the pupils constrict. You're looking at, are they brisk is a term, sluggish is a term, okay? So are they younger? Sometimes older people can be sluggish, and you wanna make sure that it's equal. One, they both constrict about the same, okay? So we're looking for constriction and equality on both sides. We always, because you have two sides of the brain, right? So if you got a blown pupil on one side and it's working on the other, that means you might have some brain damage on that side. You're always looking for equality in everything when we do it. So his pupils were equal. I'm gonna have him follow the tip of my pen or my finger or whatever, my light. That's called accommodation, okay? So that looks good. And then I'm just gonna say, okay, I'm just gonna kind of feel no swelling here. Is any tenderness? No, no tenderness. And I just say, okay, that's good. You can look in here. It's always a good thing. I didn't do that the other day. I didn't look in Jesse's mouth, but look for pink and moist is what that should be. And then I'm just gonna say, okay, well, I'm gonna listen to your heart now and then your lungs. So just rest easy and just take normal breaths. So remember the M-tap. This guy has breasts. So M is right where your apical is. That's the mitral valve. T is about 8 o'clock. That's the tricuspid valve. Up here is the aortic valve. And over here is the pulmonic valve. What you're listening for is the heartbeat regular? Is it skipping any beats? Do you hear any murmurs, anything like that? So a normal sound would be lub-dub, lub-dub, lub-dub. It's regular rate and rhythm. Regular rate means it's between 60 and 100 on an adult, and rhythm means that it's not going lub-dub, 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 okay? So his heart sounds good. So I'm making note of that. That's normal, okay? So I'm making note of that. And I'm gonna listen, take nice slow breaths for me. Breathe in and out. You can just listen to 1 or 2 breaths. If there's something there, maybe you would want to have them take another breath, but if it's clear, it's clear. Take another breath for me, nice and slow. In through your nose, out through your mouth. That's good. Okay? Then I'm going to go under the gown. And I'm going to listen about midways. Nice deep breath for me. That's good. Nice deep breath for me. And I'm going like right about here, about middle ways, okay? Nice deep breath, and that's good. Now I have an option. I can continue on with the stomach, or I can stay with the respiratory system. If you're gonna, you always want the patient sitting up as much as possible because it takes stress off the diaphragm. That's the easiest way for them to breathe, okay? So we're gonna sit him up. I'm gonna do the upper lobe here. Nice deep breath. Nice deep breath, upper lobe there. Go down just under the scapula, nice deep breath, nice deep breath. Okay, lung sounds are clear throughout. So now I've listened to the heart, the lungs. You want to look, listen, and feel for the abdomen. So, okay, so I'm going to look. And since I'm putting an NG tube in, we're going to pretend, even though you can, when you do your assessment, it's flat, okay, and it's soft, okay, but because he needs an NG tube, I'm going to simulate that it's kind of rounded and firm. It's distended. It's filling up, and that's why we have to have the NG tube to decompress. So I'm looking, I'm going to say it's rounded and firm. He told me already that he's hurting right here, so I'm going to keep a mental note of that, and I'm going to listen. I always start in the right upper quadrant, and you just listen for gurgles, and you're paying attention. If you just hear one gurgle, that's good. If it takes a long time before you hear a gurgle, then his bowels would be hypoactive, okay? They're not moving very much. But if within a minute or two you hear a gurgle, you're good to go. If you hear lots of gurgling, he's hyperactive, meaning he's probably got diarrhea, stomach cramps, and all that. So I just call it that I hear bowel sounds unless it's hypo, slow, or hyperactive, okay? So there I heard a gurgle, there I heard a gurgle. Go into left lower quadrant, hear a gurgle. Right lower quadrant, hear a gurgle. Now I'm done with my stethoscope. I can take it off, put it around my neck, whatever, and then I'm going to palpate, okay? So I'm going to lay you a little flat so I can kind of examine your abdomen here a little bit better. And you can palpate them through their gown, okay? So he's already told me that he's got pain here. What was your pain like? Is it sharp, dull, achy, throbbing? What is it? Oh, it's sharp. And you said it's a 3, right? Yeah, it's a 3. So let me know if this increases your pain when I press here. No, that really doesn't have any effect on it. If the pain is there, it doesn't increase it. So it's not like it makes it hurt more when I press, okay? So I say, okay, that's good. And then I go over here and press. And just use a little, just kind of manipulate a little bit with your hands. Then I'm going to go down here to the lower quadrant, left lower. And then I'm going to say, while I'm doing this, when was your last bowel movement? It was yesterday evening. What was it like? Was it firm? Was it diarrhea? What was it? No, it was kind of firm. Was it normal for you? Yeah, it was normal for me. It was about the same amount and all that stuff. Was it brown? Was it black? Whatever. No, it was just regular brown. Okay, good. He had a normal bowel movement for him yesterday. And then I'm going to palpate over his bladder, feeling for distended bladder, meaning full. And it doesn't feel distended. But while I'm on his bladder, I'm going to say, when was the last time you voided? Oh, I voided about 6 o'clock this morning. Okay, what was that like? Was it, and really if we're in a hospital, we have them save all the urine. They're peeing into a urinal, or if it's a female, she'll be peeing into a hat. We tell them not to throw it out because we measure intake and output so we can actually visualize it. So I'm going to, oh, it's in the urinal right here beside the bed. And I'm going to look at it and say, okay, well that's clear, meaning there's no sediment, it's not cloudy, and it's yellow. Okay, it's not dark yellow, it's not real light yellow, it's just a yellow color. So, and that's normal. So, okay, so I actually visualized his urine. So now, this is called neurovascular check, but I just worked my way down the body, so we're back to the neuro again. And I'm gonna say, put both your hands up here, he can't really cross them, and I'm gonna feel radial pulses. And feel if they're equal in strength, okay? And they feel equal in strength, okay? And then I'm going to say, squeeze my hands. This guy can't do it, but we'll simulate. Okay, that's good, nice and strong. He's equal on both sides, okay? So now I'm pretty much done with this guy. About all I have to do now is I need to feel the pulses on your feet. Right here between the big toe and the next toe, there's bones right here called metatarsal bones. And then you'll come right up here and you'll feel, I don't know what this bone's called, but you'll feel where the two actually come together, okay? That's about where you'll find the dorsalis pedis pulse. So you want to palpate there, and you palpate both sides at the same time, okay? All right, those are the equal strength. We've got good pulses. So that means this is the furthest away. If he's got good pulses here, that means he's got good circulation. You can still check capillary refill if you want to. I forgot to do it on the fingers. Check capillary refill. And then I'm going to say, okay, can you roll over on your side for me? I just want to look at your back and make sure you don't have any skin issues. Okay? And you'd also want to look, you could also look at his legs. There's no or her legs. There's no wound there. Okay? Turn him over. I'm not gonna turn him over. We'll just simulate, okay? Look at his back. Everything looks good. So skin's, and you wanna feel the skin. Is it warm, dry, intact? I don't chart hair distribution unless I notice that he's bald down here, or he's got bald patches. That could indicate poor circulation. You wanna look at color. Is it any abnormal coloring? Everything's normal on this guy as far as skin's concerned, okay? So my head to toe assessment now is done. Okay, now we're gonna put your NG tube in, and I'm gonna do this by myself, and I'll show, because I'm gonna make you guys do it by yourself, no tech help. I'm gonna set you up here a little bit. Do you know what an NG tube is? No. Well, you're gonna have to put a tube in your nose, and it's gonna go down your throat into your stomach, because that's probably why you're having all this pain. Something's going on in here, and it's basically gonna suction out your stomach, and it should relieve a lot of your pain down here. Oh, that doesn't sound like fun. No, it's no fun at all, to be honest with you, okay? So I got him sitting up where I want him. I'm gonna get my suction going, and I want you guys to do this too. I actually want you to turn the suction on. You're not gonna really get a reading here unless you put your thumb over the end of it, okay? And just put it down in the green range, but the order's gonna be for low intermittent suctioning. So that would be in the green. So I've got it set right where I want it, and I'm just gonna leave it running. And I'm just gonna set the tube right there where I can get to it. Get my other stuff over here. Got my syringe. Okay, and it doesn't have the cap on. I'm just gonna go ahead and put my 30 of air in it, because I know I'm gonna need it. And you can set it right back here or lay it on the table, it doesn't matter. Got my NG tube, I'm gonna open my NG tube up, pull my NG tube out, okay? And, okay, good. All right, so the next thing I do is, before I do that, I'm gonna get my tape ready. And this is the kind of tape I like to use for this. It's not too wide. You just need a couple inches, okay? And then I'm just gonna tear it right up the middle, just like that. And I wanna set it somewhere where I can reach it, because I'm gonna be over here, so I don't need to, you know, have to move around a lot. So I'm just gonna set it somewhere that I can reach it. I can actually reach it right there, okay? This is a clean technique. We could possibly come into contact with body fluids, meaning gastric content. So we're gonna put gloves on. Before I even get started, so I don't forget. I've got my Sharpie, and I'm gonna measure his nose to his ear. I'm gonna take my Sharpie and make a line around there, okay? And then I'm gonna measure from his ear down, I keep saying his xiphoid process, which would be about here. But notice there's a black mark there, so we're gonna pretend that's the mark, okay, just so you can see it, since I don't have a Sharpie, all right? So I know I need to go that far to that mark. In reality, I need to go down to here. If I had a Sharpie, I would do that, okay? So you're gonna explain to the patient, you can't do this without the patient's help, okay? So you tell him, okay, what we're gonna do is we're gonna insert this NG tube, and you wanna have it clamped before you get started. Because if you don't, it's gonna run out. And this is your splice, so just go ahead and set it over here. So you'll be able to hook the two together. Okay, so what we're gonna do is we're gonna stick this up your nose. What you're gonna feel is gonna come to a stop, and you can tell him it's his turbinates or whatever, probably not gonna make much sense. And I said, once it hits, we're gonna keep your head back, and if you're gonna feel pressure, because I have to get past that, okay? And then once I get past that, I'm gonna have you lean forward and swallow for me. And when you swallow, I'm gonna advance the NG tube. So we really have to work together here. It's gonna hit your gag reflex. It's gonna make you wanna gag probably, but just fight through it with me for 30 seconds and we'll get this done. That's what I tell them all, okay? Just be honest with him. He knows, that way he knows what to expect, all right? So, the one thing you always want to ask that I didn't do yesterday, is there one side of your nose that you can breathe out of better than the other? Yeah, my left side's kind of stuffed up, okay? If his left side's stuffed up, we're gonna go into the right side. I'll just say, okay, he's breathing better out of this, it's more clear, so this is the side we're gonna go with. So I'm gonna push it in. I'm it's already dead stopped right there. That's as far as I'm gonna be able to put it. And but I'm gonna pretend I'm past the terminate, okay? I'm gonna say, and he's gonna go, oh, his eyes are gonna be watering. It's not comfortable, okay? So I'm gonna say, okay, now we need to tilt your head forward. Now again, remember, you can use the cup of water. The book shows using a cup of water with a straw. You having them hold that cup of water and take a sip, and then when they swallow, you advance. I never use a cup of water, but if that's what you want to do, it's fine. I'm not going to require for the checkoff. I just say, okay, what I need for you to do is swallow for me. He's going to swallow, and when he swallows, I'm going to push, and then I'm just going to hold it. And you can only go back a little bit. You go way back here, it's not going to do anything. You can only go back a couple inches at a time. And then once I got him swallowed and I advance, I'm just going to keep going as long as he can tolerate. Okay, swallow, advance. All right, swallow for me one more time, advance. All right, we just got a few more to go. Swallow, swallow. If it comes out and he gags and it comes out his mouth, it's like, okay, well, we're going to have to do this again. You pull it back to your first mark and just say, okay, we're going to do this again. Swallow. Eventually they'll get it. Oh, hey, look at that. It went. He swallowed for me. All right, good. So it went. Okay, so he's got it right there. I have to verify it, right? Well, I can't I'm not going to let go of this. I'm by myself. I couldn't get a tech to help me. So I'm going to put this on his nose. You just pull these apart. It doesn't matter which side you do first. You just wind one side around. Like so. And then wind the other side around. Like so. Okay? So now the NG tube's in place, I've got it clamped, so I didn't really have to worry about it leaking. So now I'm gonna put my stethoscope on. I'm gonna say, you doing all right? He's doing good. So I'm gonna say, okay, what we're gonna do now is I'm gonna listen to verify that I have it placed correctly. I'm gonna get my stethoscope. Remember to hold it above him. If you don't, you're gonna have stuff everywhere. All right? I get my stethoscope, put it right on the xiphoid process. I hold these two things together is the way I do it. And then you want a brisk push. Okay, okay, I heard air, so we're good to go. I want to keep this up still. Set that down. Bam, put the suction. Then I'm going to make myself a flag. And I'm going to have a safety pin with me, which we don't have any safety pins here. And I'm just going to put it where I can kind of make a flag and there's a little slack in it so he can turn his head, all that sort of stuff. Try to make it comfortable, and I'm just going to tape it right there to his bird. I'm going to pin it right there to his gown. Okay? And you're done. That's putting an NG tube in. Okay? Part of the checkoff is going to be medications. Okay? So what or feedings. You do it, it's the same way. You have to pour it in. So let's say we want to give medications. I told you we do it. You'll have the little plastic cups that they use for like drinking water cups that are like 6 or 8 ounce cups. You crush up one pill at a time, put the powdery stuff in there, pour some water in the cup. Once you get that, if you give medicine, you can't do it while he's being suctioned, so you have to disconnect him from the suction. And we won't hook, and the order will probably say withhold suction for 30 minutes or whatever. I've got my drinking cup. I'm just going to pour it in and watch it go in. If I'm holding it here and it's going in kind of slow, raise the gravity up on it and it'll help it flow in better, okay? Once I get that medicine in, then I've got another thing with water. I pour 30 mils of water in, let that flush through. Then the rule is you've already got your medicines pre-crushed before you get in there, however many you got. Take the next medicine, put it in the cup, pour some water in there, mix it up really good, pour it in there, flush it with water, okay? Like I said, what you're gonna see the nurses do, they don't take time to do all that. They're gonna crush everything up all together, put it in the drinking cup with water, they're gonna mix it up as best they can, and they're gonna pour it in, and there'll be some powder residue left on the bottom of the drinking cup. They'll just pour some more water in, try to mix it up, and keep doing that until they get all the medicine to go through there, okay? And then once they do that, then they do 30 mils of water. And once you got all the water flushed in there, you're good to go. Take this off, clamp it, and you can stick it in his pocket. If he has a pocket, if he doesn't have a pocket, you can just kind of stick it behind his pillow or something, okay? And then you can turn the suction off, and then once, and don't forget to put it, I had it on regular suction, don't forget to put it on, the order was for low intermittence, so don't forget to switch it over. I didn't do that. Okay, any questions about the NG tube? Yes?
Seen a lot of NG tubes in babies. Is it any,
They're actually feeding tubes.
so it's not the
Probably.
same?
No, it's the same, you can feed, you can suction.
How
This
would
is,
you get it to go down into a baby's stomach if you can't, you know, if
Can't
they
get
don't
them to
respond
swallow?
and,
you just, actually, a lot of times they won't swallow either, they're working against you. If it goes through the nose, I've never had one go into the lungs, okay?
so that's like really rare.
Well, it can happen, I just said it's never happened to me. So I try to get them to swallow, and when they swallow, I try to advance as best I can. Once you get it, he's not on suction anymore, but he can't eat. That's the wrong one. And he's on regular feedings, okay? So every 4 hours we gotta feed him. What you do is, the first thing, and don't forget this is very important. The first thing you do, he has to eat, is it's called aspirating. We're checking residue. If the doc wants him to have, I don't know, 120 mils of something or 200 mils of something, like every 4 to 6 hours, you wanna make sure that the patient's digesting it. So what you do is you stick this in here and then you actually pull the stomach contents out. And you'll have to have a container or something in case it's more than the syringe will hold. This is a 60 mil syringe. So, and you measure it, okay, so there's 60.
Would you put it in like a,
You
like
put
when
it
collect
in some kind of
specimen?
container, so you can take it back out. We're gonna put it back because there's electrolytes and there's different things in there. So there's 60. Oh, that's about 15, so he's got 75 of residue. Look at your book. The book says anything 100 or less, I think, look it up in your book. If it says 100 or less, you replace it, just put it back. So I got 75, I'll put that in there. Then I can clamp this if I need to. Whatever I put my 60 in, I pull my 60 back out. Put that in there. And now I'm ready to feed, okay? The book says if it's like 100 or less, replace it and go ahead and do your feeding. But if he's, like if we're putting 200 or 250 in there and he's got like 180, he's not digesting anything, right? So we're probably gonna, then I think the book says if it's over 100, replace it and call the doctor. Don't do the feeding. Let the doctor know, because it's not being digested. It's not getting into out of the stomach into the small intestine, okay? But double check me on the book, I'll double check it too. But I think the book says 100 or less, replace it, continue with the feeding. If it's over 100, replace it, hold the feeding, okay? Don't forget that part, and then you always flush after you get done with the feeding. You flush 30 mils of water. The book may say 30 to 60. I just do 30, okay? After you're done with medicines, you flush after everything, okay? Because we don't want these holes to clog up. You can look at your NG tube. I'll go ahead and take this off. We don't need it anymore. But you got these holes here. If you don't get the medicine crushed up really good, it'll start clogging around these holes, and now all of a sudden we've got a clogged up NG tube. I wouldn't want to have to go through having somebody pull it out and put a second one in because they messed up and they didn't do their job and they clogged up. Same thing with feeding. You know, it's thick liquidy stuff, it'll get crusty, and that's why we flush it, but it can get crusty and build up around these holes, and all of a sudden we got a plugged up NG tube. We don't want that, okay? So make sure you always flush it, and then for feedings, you always aspirate. It's called measuring the residual, okay? You always measure the residual, and then make note of that, okay? So, any questions about that? All right, so I'm gonna show you sample charting. It's hotter than blazes. If you look, whenever I gave you these, there's a front and a back, okay? And we'll talk more about the back later, okay? But whenever you look, when you look at the orders, it may say that the patient needs a bath, He could be up without assist, but he wants to dangle, that stuff, you'll circle that stuff, so you'll remember to do it. It'll say NG tube, insert, or discontinue, NG tube irrigation. You make sure that you check off on all those things, based on whatever. If he's on O2, there's a place here for O2. All these things, safety, bed rails, side rails up ×2, whatever, bed in low position. And you make those check marks, okay? There's a place here for vital signs. Vital signs are not part of your assessment. Usually the instructors, we didn't do it this year because I never do it, but they'll do vital signs and assessment checkoffs together. The students think they go together. You do not chart vital signs with your assessment. There's a different place to chart vital signs. That way somebody doesn't, the doc wants to look at what the trend is with the vital signs, the blood pressure going up, down, staying the same, whatever. He doesn't have to go through all these nurses' notes to see. It's right here on the chart, okay? I think you got I's and O's on here. Yep, you got patient's weight, intake and output. It's got broken down 6 to 10 a.m. How much oil did he have? How much IV did you irrigate? So part of the I's and O's would be how much fluid you put in there in the feeding, how much you flushed. That's part of the intake. You would have to keep track of all of that, okay? And then there's a place for you to sign and put your initials, okay? But we'll go over that part later. What I want you to see is I charted this already. And I want you to see how I chart it, so you can chart it that way. And we'll go over the charting. Take one and pass them around. I think there's one for everybody there.